ventricular restoration and 60% in non-ischemic DCM received surgical ventricular restoration. Surgical ventricular restoration is effective in patients with two major conditions. 1. Large left ventricular volume, more than 80 milliliter of left ventricular and the systolic volume index, or the left ventricular diastolic diameter more than 75 millimeter. 2. The lesion site should be identified. According to the site selection, anteroseptal restoration or posterolateral restoration procedures are effective. In recent study, after the reassessment of stitch trial and postoperative endosystolic volume index, they stated that postoperative endosystolic volume index less than 70 to 75 milliliter showed survival benefits after the SVR. We had already described the similar finding in 2011, as cutoff volume after SVR was less than 90 milliliter of endosystolic volume index after surgical ventricular restoration. For surgical ventricular restoration, we selected either anteroseptal restoration as EVCPP or SAPE, or posterior restoration procedure for posterolateral restoration. This scheme shows incision line of EVCPP, SAPE, or PRP. For SAPE operation, the left ventricle incised anteriorly and use large oval-shaped patch to exclude large anteroseptal akinetic lesion. In the lesion of left ventricle is present at posterior wall, posterior restoration procedure are indicated. First, preoperative findings show the akinesis of the posterolateral wall, and therefore, second, posterior wall of left ventricle between papillary muscles is removed. Third, preserved bilateral papillary muscles. Preservation of continuity between papillary muscle and the mitral annulus seems to be very important to preserve left ventricular function. Finally, cryoablation is performed at the cut edge and mitral posterior annulus to prevent VT in late after surgery. We found the most important factor for SVR was site selection before operation. We started to use speckle tracking echo, which was easy and repeatable examination to find accurate lesion. This is a finding of speckle tracking echo in normal heart. The kinesis of the 8 segmental walls are synchronizing, and the kinetic wall motion is in red. We also found that the left ventricle apex always shows counterclockwise 15-degree rotation in normal heart. However, the rotation disappeared in dilated cardiomyopathy. In speckle tracking echo, the kinetic lesion was easily seen as red, and akinetic one is blue. These figures show the findings before and after the safe operation. This is the strain with spectral tracking echo before and after posterior restoration procedures. The desynchronizing akinetic posterior wall strain was completely removed after resection of posterior lesion, and thus the other 7 wall segments became synchronic to improve cardiac function. After the selection of the lesion site and operative procedures and making the LV size in adequate volume, the long-term survival after surgical ventricular restoration improved dramatically, and the longest one is surviving more than 22 years after SVR. In our recent new findings, in patients with preserved apical rotation, the non-transplant surgery is more effective than those with loss of apical rotation. In conclusion, non-transplant surgery for dilated cardiomyopathy was useful if we select the lesion site and operative procedures to make accurate LV size after the operation. The preserved LV apical torsion was an important factor for the post-operative prognosis. In conclusion, ladies and gentlemen, our result demonstrated that the SVR was effective in indicated patient with relief of symptom and benefit for survival as long as more than 20 years in our experiences. If you have any comments or questions, please email me in Japan. My email address is in the final slide. Please contact my email address in Japan if you have any comments or questions. Thank you for your attention.
For those who come later, so in this session we have 2 videos and 1 speaker. The first video has just finished. But because we cannot ask Dr. Isomura, I just ask your opinion, Dr. Patterson. In the U.S. Or Cleveland Clinic, do you still do this surgical ventricular restoration, or you go ahead with the VATS?
No, I think we do some door type procedures where we have scar areas of scar, and so of course we do door procedures in patients who have scar and in essence left ventricular aneurysm and akinetic, very dilated areas and so, but we don't really have a program where we look at every patient with dilated cardiomyopathy for, say, these dyskinetic areas and so. I think this is an interesting approach, and I think we could certainly do more, and when you have these paradoxically moving areas, I would believe in the procedure. The selection of patients, I think, is very important.
And in Japan, can I ask? Yes. In Japan, After the reimbursement of LVADs, so are you, I mean, this kind of surgery are still popular or not?
Not so popular, but I think it's, the Dr. Isomura is very specialist for this kind of surgery. And as you mentioned about the door procedure, in Japan, more than 10 or 15 years ago, the door procedure is very popular. But after the door surgery, the heart shape of the heart is not good because of the not ellipsoidal. So the Dr. Isom, in his presentation, he have a lot of save surgery, septal anterior ventricular exclusion. It's make the heart the ellipsoidal. So we prefer the save surgery rather than the door procedure.
And do you know if those kind of patient has mitral regurgitation and you have to repair mitral valve, you repair it from ventricle or from atrium when you open?
Usually the ventricle, from ventricle apex. But sometimes Dr. Isomura performed the mitral angioplasty first from the left atrial approach and then he moved to the ventricular surgery.
Dr. Tawai, can I ask you a little bit more about that speckle echo? Is it hard to perform or not? Dr. Tawai is cardiologist from...
Not so hard, but you need a bit training, but not so hard.
But every cardiologist can do this.
Yeah.
Thank you. So I think we go ahead with videos from Dr. Tong regarding pulmonary embolectomy. ครับของดร.ตองได้เลย
Dear friends and colleagues, it is my pleasure to be speaking to you today. I would like to thank the ASCVTS and to VSAC for the kind invitation. I'll be speaking on the surgical management of chronic thromboembolic pulmonary hypertension, or CTEPH for short. I'll speak about the pathogenesis and pathophysiology, how we diagnose the disease, the surgical treatments, including a surgical video, and finally, alternative treatment options such as medical management and balloon angioplasties. So pulmonary hypertension arises from a single recurrent pulmonary embolus in patients who have CTEPH. When you have an incomplete resolution of the embolus obstruction and narrows the major pulmonary arteries, this ends up developing into progressive distal small vessel vasculopathy over time. When you have the initial thrombus formed, if the body is not able to fully eliminate the thrombus with a combination of anticoagulation, you may end up with band defects, recannulization that's partial, and stenosis. You can also have vessels that become atretic over time. Over time, this leads to increased pulmonary vascular resistance, pulmonary hypertension, and right heart failure. The incidence of CTEPH after pulmonary embolus is estimated to occur in about 2 to 3% of survivors of all PEs. And in the United States, there's 300,000 to 600,000 cases of PE. And even if we estimate that 1% of survivors will develop CTEPH, that gives a potential about 2,400 to 5,000 potential CTEPH cases in the United States. However, in the United States, we are only performing about 300 to 500 of these operations every year. Hence, this disease is severely underdiagnosed and severely undertreated. but there is hope. With the innovations in medical treatment, pulmonary hypertension can be treated much easier. Pulmonary endarterectomy remains the treatment of choice, and the outcomes have remained excellent. Balloon angioplasty is rapidly becoming an alternative, and lung transplantation is also an option. However, the outcomes of lung transplant long-term is not ideal, with a 5-year survival of only 55%, and there's persistent issues with donor shortages and risk of infection and rejection. In patients with suspected CTEPH, essentially entails any patients who have persistent symptoms after acute PE, patients who have unexplained pulmonary hypertension, or patients who have unexplained dyspnea. In these patients, the screening include an echo to look for right ventricular failure, as well as pulmonary hypertension, and a VQ scan looking for perfusion defects. CT pulmonary angiogram is performed to isolate and locate the locations of the thrombus and the clots, as well as a right heart cath looking at the hemodynamics. This is what a normal VQ scan looks like. You have both normal ventilation and very uniform perfusion throughout the entire lung space. However, in patients with CTEPH, on the top panel, top row and the left side, you see a patient that has a completely normal perfusion. However, you can, in the middle and the bottom row, you see patients with the perfusion having areas of decreased perfusion or complete absence of perfusion. These wedge defects are pathognomonic for CTEPH. On the image on the right, you can also see perfusion defects. However, these are much more limited, and this is what you would typically find in segmental CTEPH. On CT scan, you can see webs. You can see vessels that become atretic. You can see thrombus that line pulmonary arteries, as well as pulmonary artery dilatation. And finally, you can also see stenoses. Looking at the lung fields, you may see what's called Mosaic Attenuation, where you have areas of hypoperfusion and areas of hyperperfusion. And also, you can see bronchial artery that become engorged and become collateral flow to the lung parenchyma in areas where you have disease. When a CT scan is not fully clear and the location of a clot needs to be further characterized, we can perform pulmonary angiogram. In a pulmonary angiogram, you can also see areas of the lungs that are hypoperfused, indicated by the arrows. And you can also, typically we will do a pulmonary angiogram in 2 views, LAO and RAO, and you can see narrowings, cutoffs, stenoses, pouch-like defects for poststenotic dilatation, as well as bands. Once a CTEPH is confirmed and diagnosed, we want to assess whether or not the patient is the operative candidate. And this is assessed in 2 ways. First of all, we have to make sure that the disease is technically accessible, usually lobar disease, segmental disease, and even some subsegmental disease. These are technically accessible with surgery. In patients that are too high risk for surgery and have too many comorbidities, these patients are then moved to the right side of the screen, where they will receive target medical treatment only. And nowadays, balloon angioplasties in certain centers are also being considered for patients that are not surgical candidates or who are too high risk for candidates, and also patients who have residual disease. And finally, only if a patients are not surgical candidates, are not balloon angioplasty candidates, and have exhausted medical treatment options, are they considered for lung transplantation. In the operation itself, we will do this operation under circulatory arrest. The patients will be cooled down to 18 degrees on their bladder, which includes about 30 minutes of cooling. Patients will be given phenytoin, propofol, steroids, and will enter circulatory arrest and perform an endarterectomy starting on the left side. Typically, this takes about 15 to 20 minutes. We'll then reperfuse the patient but remain cold, and then go into circulatory arrest again, and then perform the endarterectomy on the right side and rewarm the patient. The setup during the operation, I'll have a vent in the pulmonary artery. I'll have a vent in the ascending aorta, and as well as a vent in the left atrium through the right superior pulmonary vein. I'll use a HeartNet device with one strand in the transverse sinus and one on the oblique sinus, and then I also will use near-infrared spectroscopy for the brain to look at the brain saturations. Typically, over the course of the circulatory arrest period, the brain sats will drop, and when we reperfuse within about 2 to 3 minutes, the brain sats will recover. If the brain sats drop under 20 points from baseline or to absolute value of 40, we may stop the circulatory arrest period and reperfuse the patient, and then re-enter circulatory arrest to complete the dissection. We do need some specialized instruments, and our endarterectomy knives are helpful to get into the plane sometimes, and we have a special suction that has also a rounded tip that we can use for the dissection. We have various ones with different angles to help us achieve, access all areas inside the pulmonary vasculature. Reduction in the PVR is key to successful long-term outcomes. In a study by the University of California, San Diego group and Mike Madani, in their cohort, patients that had a residual PVR over 6 Wood units had an in-hospital mortality of 10%, versus those that were under 6 Wood units had an in-house mortality of less than 1%. So here is a recent case that we performed. This is a 73-year-old male with a history of COPD, hypertension, and prostate cancer who's been increasingly experiencing short of breath about a year ago. We performed a VQ scan, and patient had abnormalities in both the ventilation and the perfusion. However, the abnormalities in the perfusion were more pronounced than that of the ventilation. And also on echo, there was enlarged right ventricle, moderate to severe pulmonary hypertension with an RVSP of 75, and the left heart cath confirmed the pulmonary hypertension. On the CT, you can see thrombus that is lining the pulmonary artery, and the pulmonary artery is dilated with web defects in the segmental segments on both sides. This is the video of the operation itself. So as we're cooling the patients, the hilum of the lungs are prepared. We dissect the hilum, the lung, through the pericardium and into the pleura. The HeartNet device is also used to position the heart. We place a vent in the pulmonary artery in the right superior pulmonary vein. We typically don't arrest the heart for these periods, but the hypothermia will cause the heart to stop. The heart is then lifted towards the right side of the chest, and the pulmonary artery is open. Once the pulmonary artery is open, we'll use pledgeted sutures to tack up the vessels, and the pulmonary artery will be open to the level of the pericardium and sometimes even beyond that. Once we're inside, the scar is identified, and we start developing a plane between the scar itself and the pulmonary artery intima. It is very important to be in the right plane. If the plane is too shallow, we may not be able to extract the clot, versus if the plane is too deep, we may end up with a ruptured pulmonary artery, which can be a catastrophe. So once the plane is developed, the dissection will be carried more distally into the smaller and smaller branches. Eventually, we'll get to the point where the size of the vessel becomes smaller than the size of the instruments, and the disease will be split into the various segments themselves. Each one of those segments are entered individually, and the disease is extracted from each of the segment and subsegments, and you can have 15 branches or even more where you may need to extract the disease. Once you reach a certain point and your instruments can't go farther, typically you'll start applying gentle traction, and this will allow you to start removing the more distal disease. It is very important not to pull too hard, as you don't want to tear the clot and leave a residual disease inside. You want to make sure that all the disease is removed in its entirety, and you get all the tails of each segment and subsegment. This is continued for the rest, and then we reperfuse the patient and close close the left pulmonary artery. As we're reperfusing the patient, I'll then go to the other side of the table. The SVC will be lifted to expose the right pulmonary artery. In cases where the exposure is poor, the SVC can even be transected for additional exposure, particularly in redo cases. So the pulmonary artery on the right side is open, and once it's open, the incision will be carried down to the level of the pericardial sac, and sometimes even into the pleura, and the plane will be developed. This plane will be carried further distally, as you can see right here, and also carried into each branch. Again, we want to make sure that we are in the right plane, and a considerable amount of time is spent to ensure that we're in the right plane. Typically, the intima of the vessel will have a nice, smooth, pearly appearance that is slightly yellow, and clots will have a more nodular appearance that is more whitish. And each of the branches are then entered, and each of the branches are cleared individually, as you can see right here. Once the dissection is carried into areas where the instruments can't go any further, gentle traction is applied to allow the extraction of the tails of each individual segment. This is what the final specimen looks like, and it's important to get all the tails, as you can see, and this is what ensures that the distal vasculature will be opened up afterwards. On this patient, the preoperative PA pressures were in the 60s systolic, and postoperatively returned down to 30/16. The echo normalized, and the anticoagulation was initiated. VQ scan was also performed, which showed an improvement in the perfusion bilaterally, and patient was discharged on day 8. On the medical treatment side, there's now 17 drugs that are used to treat pulmonary hypertension. Of those, the one that's approved for CTEPH is a drug called Riociguat, or Adempas. And this drug was studied in a placebo-controlled RCT with 261 patients, both inoperable and who have residual pulmonary hypertension after surgery. The 6-minute walk improved by 46 meters in the patient that received the Riociguat drug. In cases where the disease is too distal for surgery, or in cases where the surgery was not successful in extracting all the disease, balloon angioplasty can be considered in these patients. With each session of balloon angioplasty, a different part of the lung is opened up, and typically it may require 5 or 6 sessions before all the areas of the lungs are opened up. This is an example of one of our cases where we performed a balloon angioplasty with a good outcome. The Japanese have been very proficient in doing balloon angioplasty, and they had good success with a mean drop in pulmonary artery pressures by about 20 points. However, they did have high complication rates with pulmonary injuries and hemoptysis. The Germans, on the other hand, in their experience, had a less drop in pulmonary hypertension, but complication rates were less. Most likely explanations with that the Japanese groups tend to be more aggressive when doing the balloon angioplasties. These are some of our other recent cases that we have. Some of these diseases are very bulky, and others, the diseases are less. But overall, if you look at our entire cohort, we have a drop in pulmonary pressures from a 45 mean pre-op to about 25 mean post-op, with an increase in cardiac index and a significant drop in the pulmonary vascular resistance from 6.6 down to 2.4 Wood units. In summary, patients who have main arteries, who have disease in the main artery, lobar, and segmental arteries, and even some subsegmental arteries, can have a pulmonary endarterectomy. Those patients who do not have accessible disease but still have disease that can be reached with a balloon are candidates for balloon angioplasty. However, patients that have only microvascular disease are best just treated with medical management alone, or with lung transplantation. Some of the take-home points: CTEPH is a condition that is underdiagnosed and is rarely diagnosed by accident from imaging from another type of a study. Therefore, this is a disease where you have to go and look for it and have a high index of suspicion. Any patients that have persistent symptoms after a pulmonary embolus, you want to think CTEPH. And many patients with CTEPH do not have a history of acute PE. VQ scan is a screening test of choice, and the imaging that's required are very detailed. You need a thin cut CT PE protocol, and when that's not diagnostic, then a pulmonary angiography is required. PTE remains a treatment of choice with excellent long-term outcomes. However, balloon angioplasty and medical treatment choices are becoming more and more available and can be also offered in select cases. Overall, this is a disease that, as the surgeons, we can provide a dramatic benefit for the patient, not only for their life expectancy, but for their symptoms. And it's the only form of pulmonary hypertension that can be truly cured. Thank you very much. Dear friends and colleagues, it is my pleasure to be speaking to you.
Any comments from the floor? Dr. Patterson, this circulatory arrest of 20 minutes, and after that perfusion again 20 minutes. So this is the Cleveland Clinic policy, or?
Yeah, I think it's the same in San Diego. I think they do it in essence the same way. The key to develop a program like this is, of course, to have a pulmonologist who is aggressive and who diagnose the patients and who believe in the procedure. And our start and development of this program was pretty slow. And the reason for that was that we didn't really have pulmonologists who looked for these patients and who were enthusiastic about the procedure. That's the key to it. And then you got to have, so Dr. Medira was the surgeon who did this, and we really had so few cases that it wasn't really possible to say move anywhere with it. And Dr. Tong, say the first thing he did was, when he was asked to take that over from Dr. Medira, was to go over to the pulmonologist and talk to them about it. And that's really the key to his success. And the way, say, Mike do it is to say superb. You know, he is very good at finding the plane, and he's been very successful with these procedure. And I think it's like everything else, that once you get the pulmonologist who's interested, and once you show him that this is really worthwhile, then it starts rolling, and our program is developing. And I'm sure that in 5-6 years from now, Dr. Tong will have 500 cases.
And from coronary end atherectomy, every time we try to end atherect those plaque out, it's always not perfect, but it looks from the video it's easy for him. I mean, is there a learning curve to do that smooth endarterectomy like that? Yeah.
You know, I was before I was, when I was running the lung transplantation, I really felt that this belonged to the lung transplant groups, and I scrubbed in with Medira on many of these cases, but you know, there was really nobody among our pulmonologists who were so to say interested. So we just had too few cases, but the cases I scrubbed in, I think we were very successful. But I think that that Mike is even better than Medira on doing it. He does it very, very well, and that's why I think it's rapidly developing. So You got to learn it, and I think you can go to Mike. He's got enough cases now to be teaching.
In some cases, there are no scar and only a thick wall. So how to develop the dissection pain?
I'm not the right person to ask. so I don't think I should answer that, but it's obviously doable. Yeah, I think Mike has been, say, very successful. They haven't been successful in 100% of the cases, and maybe the fact that we have alternative pulmonology treatment options for this is good for the development of the activity. Once the pulmonologists have some treatments of their own that they can offer the patients, they are suddenly more interested in diagnosing the disease and offering treatment. So I think that, and also when the surgical treatment is not fully successful, they can, so say, help out with further interventions.
Thank you. So we come to the last talk for this session by Dr. Dwight. He presenting the MitraClip for functional MR.
Yeah.
Please.
First of all, I just let you know that I'm not a formal speaker for this session. Dr. Twisak asked me yesterday to prepare this talk, so I do apologize if anything is not so perfect. I will do my best. Okay. I talk on behalf of the Ramatibody MitraClip team, which is 4 people. Dr. Krisda, who is the implanter, Dr. Mann, interventionist, Dr. Arpon, and I. Basically, the MitraClip, for those who are not familiar with the MitraClips, it's technically a percutaneous out-free suture that put the anterior leaflet and posterior leaflet together to reduce the MR. Okay, in this session, I will present 5 cases, and I hope you enjoy my case. And if you have any question, please feel free to interrupt and ask. Okay, let's go to the first case. The first case is a 75-year-old man who had diabetes, hypertension, and coronary artery disease. He underwent CABG. 6 months after CABG, he developed severe decompensated heart failure with low output syndrome. At that time, the coronary angiogram showed patent limar to LAD, SVG to PDA, and occlude only SVG to circumflex. And at that time, he has been found having severe ischemic MR. He had multiple admissions due to heart failure and cardiogenic shock, requiring inotropic medications. The MV surgery was turned down by CVT team because of high risk for surgery. So we have choice of treatment like this: fix the small circ, medical treatment, palliative care, and transcatheter mitral valve therapy. Here is the patient echocardiogram. You can appreciate the severe MR as well as the severe RA dilation. Just let you know that if you look at the guideline 4 years ago, the MitraClip is to be indication for functional MR with the level of evidence of C. That means the expert opinion. However, 1 or 2 years later, we have 2 major trials to add on the evidence to the MitraClips. The first one is COAP trial. It's basically the multi-center trial recruiting more than 600 people with heart failure and moderate to severe MR who remain symptomatic despite maximally tolerated medications. The patient was randomized to be MitraClip and medication arm, and the medication arm alone. The primary endpoint is hospitalization for heart failure within 2 years. And you can see that in the MitraClip arm, there was a reduction of admission with the hazard ratio of 0.53 with the significant P level. For other endpoint, the MitraClip arm also reduced the all-cause mortality. The hazard ratio is 0.6 and significant P value. If you remember, at that time, we in the Europe, they also published another trial we call MitraFR. They randomized the patient with the same fashion. However, this trial is negative trial. So the question is, what is different between two trials? I would like to summarize in these slides. The upper line is COAPT trial, and the lower line is MitraFR trial. First of all, the COAPT trial recruit the patient to the heart failure team and adjust medication as heart failure team plan. However, the MitraFR didn't mention about this process. The second thing is the baseline severity of the MR is not equal. The COAPT trial show the more severe MR at the first time before randomization. Moreover, the MitraFR trial show more LV remodeling. That means bigger LV compared with the COAPT trial. And finally, after the CLIP, the COAPT trial revealed the less severe, less residual MR. That means the MitraFR, the patient is more likely to be the LV disease more than valve disease. On the other hand, the COAPT trial, the patient fit in the valve disease more than LV disease. Let's back to our patient. He underwent MitraClip procedure, and you can see that after we clipped the mitral valve, the air pressure is dropped down, and the systolic blood pressure is jumped up from 90 to 130. Here's the reduction of the VVAF before and after procedure. This is a hemodynamic change of our patients. The air pressure dropped down from 34 to 20. Here is the echo. This is the echo before procedure. This is after procedure. You can appreciate the reduction of the mitral regurgitation. This is the full chamber view. And this is 1 year after the procedure. Some residual MR, but the patient did well. Okay, so lesson learned number 1. Don't rely on the current guideline because it hasn't updated yet after we have good 2 RCT. However, the patient selection and preparation are the key of success. Let's go to the second case. He's 50 years old dentist with history of anterior wall STEMI with cardiogenic shock. After that, he developed ischemic cardiomyopathy. He's quite doing well after PCI. However, he subsequently developed decompensated heart failure and found having severe MR. His systolic blood pressure is around 90, so he could not tolerate any heart failure medication, and his creatinine was 1.2. Here's the echo. You can see the CVMR hug the lateral wall of the atrium. This is the TE for this patient. You can see the CVMR. So we decide to put the MitraClip on this patient. This is what procedure look like. We transeptal puncture. After that, we put the clips. This is the first clip. You can see there's MR reduction after first clip, but we put another one to get rid of the MR as much as possible. And this is the final echo. This is the pre and this is post. This is pre and this is post. This is pre and this is post. In this case, we put the triple orifice valve to the patient. The hemodynamic, you can see that the mean airway pressure dropped down from 30 to 19. And what I would like to show is more than improvement of the chest X-ray and stable at 1 year. I would like to show you one important information. You can see that the gradient is dropped down from 1.2 to 0.9. So beyond the mortality benefit showing in the CTEPH trial, the MitraClip also make a patient increase blood pressure and creatinine reduction. So this means space for medication titration. So lesson number 2, beyond mortality benefit, a better hemodynamic outcome generate more space for titrating essential medications. Case number 3 is 83-year-old male with unremarkable past medical history. He admitted due to acute decompensated heart failure 1 month ago. And we found CVMR from frail P2 segment. His angiogram is normal, and he was scheduled for surgical mitral valve surgery. However, he refused the surgery. This is the echo, show the frail P3 with eccentric anterior directed jet mitral regurgitation. This is the case of the degenerative MR. In the EVEREST trial, 5-year follow-up seems that the MitraClip and surgery is comparable. But if you look at the EVEREST trial, they need some specific anatomical criteria. For example, the regurgitation jet should originate from the A2 and the P2 segment. But in our patient, the lesion is in the 3 segment, is medial segment. So it's not same as the EVEREST criteria. Here's the paper after EVEREST. They look at the patient, more than 100 patients. They exclude IEE or an very small mitral valve area, but they include all anatomical criteria that EVEREST excludes this kind of patient. What they found is the success rate of the MitraClip is more than 80%. Why? Because we have better technique. For example, this is a zipper technique. If we have a big gap in the middle, we can zip in the lateral or the medial first and put another one at the middle at the end. Moreover, the clip system has been changed over the time. This is the old MitraClip system. This is the NT system, and this is the last system we call XTR, so the longer arm for the procedure. In this particular patient, we put the clip, and the final echo looks good. The gradient is only 4, and the PV flow from the reversal become normal. The long-term result is good. This is the patient. He can walk and slow jogging in the garden. So lesson number 3, don't exclude the patient based on anatomical criteria because we clearly have the better technique and devices. The fourth case is the old gentleman with sudden onset shortness of breath for 2 weeks. He was admitted to the hospital due to heart failure and found having severe MR. He also had acute renal injury on top of CKD. CAG looks good. Here's his chest X-ray, heart failure. And after direct assessment, it looks good. However, in the 5 a.m. in one morning, he had sudden shortness of breath, cardiogenic shock, need intubation, and at that time it's very high risk for MVR. So we decided to put the MitraClip to this patient, and the hemodynamics look good, reduction of the airway pressure as you've seen in the previous case, the system echo pre and post. So lesson learned number 4, MitraClip might be an option for the selected case of cardiogenic shock patient as a life-saving procedure. Actually, this is the last case. This is a story of our most severe patient. This is an elderly patient with heart failure. He was intubated at the provincial hospital for 2 months, and at that time, his serum albumin dropped down from 4 to be 1.9. They gave at IV diuretics, and the serum sodium rising up. The doctor at that hospital unable to extubate this patient. This is the echo. You can see the frail P2 fragment over here. The ERA is 1.9. If you can remember, the criteria of CVMR is 0.4. So this is, we call torrential something MR, something like that. However, because there's no choice, much choice for this kind of patient, so we try to put the MitraClip system to this patient. In the first time, we try to put the conventional one, but you can see that the clip arm is too short for this patient because the frail gap is so big. So we changed to the new one, we call XTR, the longer arm, to grab the leaflet. And here is the result of first grasping. You can see some residual MR. So we put the second and the third clip. This is the final echo, and this is the final color Doppler 2D. The mean gradient is only 2. So in some hopeless situation, don't give up. So in summary, I show you that the update RCT show mortality benefit of MitraClip. However, patient selection and preparation is crucial. Beyond the mortality benefit, the better hemodynamic outcome generate more space for titrating essential medication. Don't exclude the patient based on anatomical criteria. We have better technique and devices. We can be an option for some cardiogenic shock patient. And lastly, in the hopeless situation, don't give up, and we can go to the EVEREST summit together. Thank you.
Dr. Tuai, what is the acceptable gradient or mitral valve area after MitraClip, and what is the acceptable residual MR that the cardiologists accept?
The grade, if you get very low number, is much better. So in my practice, I will try to limit the gradient at 4 or 5, not more than that.
Mean
gradient, mean diastolic gradient.
And what about residual MR? How much?
Should be 1 plus. You can see that in the COAP trial. If you can get rid of the MR, the outcome would be better compared with the MITRA-FR that they have some residual MR.
And in Drama TPD series, is there any patient who receive surgery after MitraClip for mitral valve surgery? In
our series, as I remember, we have only one case. That case, I think there's some detachment of the leaflet, and we cannot fix it percutaneously. At that time, the patient underwent the surgery, and finally, everything after like 1 or 2 weeks in ICU, CCU, the patient recover and can discharge home safely.
And as the cardiologist, so let's say if we have patient with ischemic MR, and we surgeon has to do coronary artery bypass, do you suggest us to do mitral valve repair, mitral valve replacement, or you just suggest us that we just only do bypass and you put the clip on?
No, I think if you as the guideline that I showed you, if the patient need CA cabbage and MVR, this is the class 1 indication. So in my practice, I will not recruit every patient to be into the MitraClip procedure. I'm still send the patient to the surgeon if the indication fit with the guideline.
Just my last short question. Sure. What is the maximum number of clips that you have done?
In the Asian, I think 3 is maximum, but it depends on baseline mitral valve area. If you have the baseline bigger valve area, you can put a lot of clips, or for example 3 or 4. But in Asian, the area, Asian people is small people, so the area is so small, so we can put only 2 or 3 at the maximum. Another issue is the location of the clip. If you put the clip at the P2A2, the gradient will be high. However, if you put it more lateral or more medial, you can stay with the low gradient. That's what we found. Any question?
Yeah, let me just make a comment that
Yep.
I've actually operated on a fair number of patients that had MitraClip. And one issue is to take the clip out without destroying the valve. Of course, we would like to be able to repair these valves, but the clips, the way they sit, I have not been successful in removing the clips without causing damage to the valve. I think the design, you need to be able to say there should be a simple mechanism to reopen the clip.
Mm-hmm. Yeah, I do agree with you. Yep.
The way that it is, usually don't do the clip except there's no choice. So it might be a patient last hope or patient will refuse surgery. I think that in surgery there's sometimes they're able to remove the clip, but they'll do valve in valve.
Yeah.
Follow that.
So the comment you said, the patient is inoperable, and so there's no patient with torrential MR that's inoperable.
Yep.
If the patient has that kind of a mechanical problem and is still alive, he's not inoperable. Mm-hmm. That's just a statement.
Yep.
So I would like, and final question, what about the tricuspid valve? Our cardiologists are putting in MitraClips in tricuspid valve, and of course the patient I see by definitions are severe failures of that.
In my practice, if the patient has concomitant tricuspid valve disease, I will send the patient for surgery. Except they are too frail to or the surgeon refused surgery, that's the only one that I introduced the clip to the patient. Okay.
Yeah.
Yep. Because I think the importance of the tricuspid valve is crucial for the patient. If we clipped and finally they had severe TR, it's unfair for the patient.
Yeah, so from I as a surgeon have a little bit of a hard time to fully understand the how you perfectly place a clip to a tricuspid valve. And that's one thing. The second thing is that we tried Alfieri principle to a tricuspid valve, and it didn't really work, and often the valve didn't hold up to it. So the sutures we put in did tear out. So we have, in essence, abandoned that idea to do surgical Alfieri on the right side. So I think my prediction is that the MitraClip for the tricuspid is not going to be very successful.
Yeah. Thank you.
So actually, as the moderator, I think this session is very good. Even with video, all topics are very interesting, but because of the coronavirus problem. But anyway, thank you very much for everyone who attend this topic.
You know, the smaller sessions are the more interesting they become. Because then you have more time to talk about the issues and so that's not necessary. I think we may be a little bit too few.
Thank you.